Let's look at the assessment worksheet that we do. This is the smile characteristics. Mind you, this is a summary video. It's geared for our staff, doctors, and I'm trying to make it geared for patients that have downloaded our assessment worksheet so you can do some of this assessment yourself at home. I hope you do. I hope you learn a lot. It might go over 10 minutes. We'll see. But I'm going to try to keep it at the 10 to 15 minute mark. There's a lot of information, a lot of details, a lot of the stuff you can look up on Google and kind of do your own research. You can obviously make an appointment, talk to one of our professionals, or maybe join into a live stream that I'll be doing from time to time right here. So here we go. This is the smile characteristics of the treatment planning assessment worksheet. The first part we're looking at, remember we have 4 categories. We are looking at the very first one, smile characteristics, and we're specifically going to go through a pictorial view of each one of these categories here. So let's look at the next slide. It's going to be lip line. What does the lip line mean, and where does it fit on our concern scale? Our concern being, if you're in the red, is a very high concern. If you are in the green, you know, you're in the green, right? We love that. We don't want to see anything in the red. If you're in the red, that may be a non-starter for sure. You have 2, 3 of these things in the red on any of the categories, it'll probably be a non-starter and probably not a good candidate for implants. You might be better candidate for an alternative solution, or unfortunately there are possibilities where there are no solutions, no good solutions, and therefore probably not a good idea to even start treatment. Waste your time and money. We're always looking at that. We're always looking at resources. Not everybody has the availability of ultimate resources. And also, we want to be successful. I always tell patients, I want to win. If I'm going to lose, I don't even want to start. So I want to win on everything. And this helps us figure out whether or not you're going to win. If you're going to win, it's because I know I'm going to win. That's the point. So here's a low lip line. So you can see the lip line here goes fairly low across the teeth. And you don't see a lot of teeth. For a cosmetic solution, this doesn't have high cosmetics, therefore it's an easy win for us. When you get into the average, where you see a nice smile, you see most of the teeth are at least more than half, maybe not 100%, but you see about half the tooth structure and you see beautiful teeth, they're all lined up, everything looks kind of great. It's still very difficult, especially if you break a front tooth. So you're not a green, actually. You're going to be yellow because we got to now make a perfect smile out of it. And the laboratory tools are handmade porcelain pieces. That is something very custom and very tailored to the person. So many times in the front, I send the patient to the laboratory so they get a custom shade if it's one of these 2 teeth. I call those the Tom Brady's, or the quarterback of the team is right there in the first 2 front teeth. Now, a high lip line is something that is very much a red when you're dealing with the front teeth, for sure. And the higher the lip goes up and the more gum tissue you see, the more difficult that case is. Mr. Ed always comes to mind. If those of you that are older that know who Mr. Ed is, when he smiles, you see a lot of gums. Next one is tissue thickness. This one's a little more difficult to tell from a patient point of view, and possibly even from a doctor. Dentists would use a tool like a perio probe, and they would kind of check under the gums, but typically you could actually see this. If you look at enough tissue, you could tell. And so I try to pick pictures that kind of illustrate a little bit more. And here's how you determine. If you look like a green, all you see is gum tissue. I mean, it's just heavy, thick tissue. And if you're only looking at yourself, maybe ask your spouse or somebody else that you can take a look at. But what you would see when it's on the other side of the spectrum, where it's very thin, you're going to see a lot of detail in the anatomy. You'll see it texturing. So hopefully this picture shows you that. As well as it's very well attached. And you can see the anatomy without trying. And you see how much tooth is really being shown here. You see just so much. And when you go under it with the probe, you really see right through that tissue. Very difficult for veneers, very difficult for cosmetic cases, especially if you have a high lip line and very thin tissue type. So we want the thicker, the thinner is more delicate and it's more difficult to handle, and sometimes our restorations cause a little bit of tissue to push back or a little recession or something, and as soon as you have a little bit of recession because you have thin tissue type, your restoration looks horrible because you see the margin between the actual tooth and the actual restoration. So this is a very difficult case when it becomes into the red zone here, and you can't fix that. That's just a biological situation, DNA wise or whatever that's there. Periodontal issues are going to plague everything. We're talking about the smile line in this case in the front 6 teeth. We want to know more about the bone loss. Do you have recession? Have you been told this from other doctors? If you've been told that you have recession, if you've been told that you have periodontal disease, you probably are going to be a more difficult case. You're going to be going down this scale here from yellows towards reds. Now here's an example of a green where you have a lot of tissue, you've got a lot of strong bone all around here. Now of course you can't see the bone here because I'm not showing you x-rays. That's the other level that you really need in this picture. But what I'm looking at really is just on the surface level. I'm looking at the amount of recession going on. This middle picture is really showing you a decent amount of recession, even though to the lay person or anybody that's not dental related, this looks pretty good. What I'm looking at here is look how inflamed and red these gums are. You're looking at the recession back here from possibly occlusion or something. Look how long the teeth actually have gotten. We got some recession going on. I bet in the x-ray in this guy, you're going to see a lot more horizontal adult periodontitis. Now, here's where it gets more severe. You got to realize if I'm in the red here, that's because also the bone is really recessed back. I don't have an x-ray here to show you either, but I can already see that there's probably about 3 to 4 millimeters of recession. There's going to be about a 3 millimeter pocket, sometimes 2, but probably more like a 3 to a 4 millimeter pocket across this case here, which means the bone starts even 2 millimeters below that pocket. So I've lost about 4 millimeters here. I've got maybe a 3 millimeter pocket, and then I got 2 millimeters. That's where the bone starts. That means the bone is way up here. You're a good 5 millimeters before you hit the bone, and that's way up here. That means this root right here typically is around 12 millimeters. Now, let's say you lost already the first 3, then you lost another 5. I mean, you're probably only looking at about 4 millimeters at most of bone around this tooth right here. So this person's really in jeopardy here. This is a case that unfortunately is going to be a very difficult case to actually deal with, especially if you get into implants or any long-term treatment here. This is a doomsday case here. Flared orthodontic problems. Freddie Mercury, look at Freddie Mercury's face. His teeth are very bucked out. That's essentially what we're talking about here. Are they an ortho case? You know, these cases over here in the red, you don't want to be doing tooth-by-tooth dentistry or implants. Typically, you don't want a lateral load to the implant. That's something where the load is hitting from the lower teeth to a flared tooth like this, hitting like this, okay? You don't want to do that, and that's what this is presenting here, a lateral load to the angulation of that implant, or you have these funny spaces or other problems on existing teeth right next door. If you look at here, it's pretty ideal. There's some separation between the lower teeth and the upper teeth. That's great. You won't pound out your implant. Here, you have an edge-to-edge space. You have more crowding. I could still kind of work with that. You're going to get chips on the prosthetic, but at least my compressive loads are there. They're not like these real heavy lateral loads that this is going to put on here. Okay, so this is how we look at flared or orthodontically needing teeth, and the patient necessarily doesn't want to go through a whole thing of orthodontics And so you got to compromise on some of these cases. The more you compromise, the more red it actually is. Okay. Let's look at color in smile characteristics. Now, color is challenging only from the aspect of there's only so much you can do to match native teeth. There's some master ceramists out there to do the ceramics for the prosthetics. However, you know, that costs a lot of money because you have one person sitting there artistically creating that look that's supposed to match. Now, if you have some really discolored teeth that have a lot of anatomy, a lot of different characteristics all in one tooth, if you lost one tooth here, it's a very difficult situation to try to match the other teeth. You're almost better off than doing veneers across the entire set, and most dentists want to do that. They want to then control the entire environment because they don't want to deal with one tooth. So that's if you're dealing with one tooth at a time. If this person lost all their teeth and did a full arch, heck, I could make miracles. Can't do it here if you're doing one tooth. Here's difficult because there are also a lot of characteristics that are happening to the teeth because of the way the teeth come together, the way the patient bites, but mostly the color characteristics have more very detail. They have speckles in it, they have craze lines. Those are very difficult things because when you do lab work, it becomes one sheet of porcelain. It's very difficult to get those little characteristics in it that the lab wants to do. But over here, where it's just a shaded color, just a straight color, very white, very easy to match. Even easier to match if one of these front teeth already had a porcelain veneer or a porcelain prosthetic. Labs have all the same stuff, so they can match that pretty easily. So that's it. That becomes more of a green. Versus native teeth are more in the red. Okay, the incisal edge. What does that mean to a patient? That means the front edge of the teeth here is the incisal edge. For those that don't know dentistry, this is probably more of a red, but it gave me a good picture to show you on here. We're really looking at chips, thickness of the teeth as they grind across the front with your lower teeth. It becomes very thin right in the front edge of the teeth. And this is kind of thin. This is probably trauma. So that's easy to fix because it's a one-time event. I know they didn't grind it away, which is more of a chronic event. Which chronic events, when you're grinding those teeth away, you're probably going to knock the restoration off. So you have to protect the restoration somehow, which can be a big challenge. And that's when you get more difficulty, when you get into multiple teeth. So as the incisal edge goes from more of a trauma case to multiple teeth going across, you probably have more of a chronic event happening where it's chronically thinning the teeth. And in this middle case here, you can see how thin it becomes. That little dark line, that little dark area right on the front part of the teeth, right there on this tip, that is thinned enamel, and enamel is translucent. So the reason why it's dark, because there's no light coming from your mouth. Light is only going in and it's casting a shadow. And so you see through the enamel and it becomes like a little darkness on that edge. So look at your teeth. If you see a little dark edge, your teeth are fairly translucent and you're going to see it show up as this little dark edge here. Now, here's a collapsed bite situation. The reason why these are red is because it's a trap. You don't want to be starting to restore things that people grind directly on their front teeth. You cannot put a restoration across these without the patient breaking the restoration right off, clean off. It's just not going to last. It'll look pretty. You get all these kind of ideas. You think you could do miracles, and of course it doesn't happen. They break off. The composites fail. The veneers fail. And now the patient's very upset. They spent a lot of money and time, and now it's not going to work. The reason why all of this, so this is a red, is they're missing at least 1/3 to a half their teeth is where it starts, where you have to really start being concerned about being a collapsed bite. The collapsed bite case requires you to do a full arch of crowns or posterior vertical dimension opening. You have to open their bite somewhere to protect the front teeth here. So this is not just dealing with the front and the way it looks. This becomes what we call bite characteristics, and we'll get to that later. But that's why this is a whole full arch case here. This is not so simple like here where you just do a filling or a veneer to fix that or do a crown. Here's like you might do multiple fillings or multiple crowns, more complex, and you hope the person doesn't chip it, or if they have a collapsed bite, it becomes much more difficult solution here, and it's not just about that, but also you change a lot about their smile, and you change a lot about how they feel about the mouth, which we'll talk about in bite characteristics later. Okay, tissue scalloping. This could be something a little bit more challenging for people to look at. Whenever you look at tissue, it all looks pink, right? Well, no, not really. Here's a pretty good example of where you don't have a much scalloped area between your teeth. And we're talking papilla is the parts right between the teeth. That's where the tissue comes together like the little scallop area. But we have nice rolled scallop tissue here. Here's about average. You know, average is still going to be a yellow because it, you know, it all depends on the lip line and things like that. But here you got to maintain it. The reason why a lot of this is scalloped is because the bone underneath it attaching or supporting that tooth structure is creating that scallop. Now, you take a tooth out, the bone wants to resorb back. You put an implant in. Well, the implant's flat. It doesn't have a three-dimension to it other than a flat plane. It's just a cylinder. And so what happens is the bone goes to that cylinder, and you have to fake the scallop in a way. You have to have techniques to do tissue contouring. But almost every time it becomes very difficult. You see pretty cases always online and in courses, but a lot of these cases are very difficult to be handled. And many of these could turn into needing grafts. So what happens is if you had an implant here, and even if you had, let's say this tooth was an implant, or one of these was an implant, the problem is that chances are there is a good chance that the tooth next door requires an implant. Now, if you have implant to implant next door to each other, the bone flattens out. What happens to that tissue scallop in between the two implants? Well, it flattens out too, right? It's going to turn into this. Well, if you have this, you know, that could look pretty good, but when your scalloping is very defined like this, the only way you solve it is squaring out the tooth more. And you got to be very lucky with the thickness of the tissue type and the height of the bone and a whole bunch of other factors come into play here. So this is not trivial. It's very difficult to maintain this type of scalloping when you start losing teeth, because that scalloping is unique to the attachment of the tissue to the actual tooth. So when you remove the tooth, you're jeopardizing and risking the scallop. And when the scallop is very defined, like here, then you better mark that closer to a red, because you know you have to have a little bit more miracles in the back pocket. Down the road, biologically, it's going to heal to where it wants to heal. It's a bit out of your control, so that could be a red. Patient expectations. Well, here I just said, just ask them. Of course, patients are going to say, well, I want to look good. Like, of course they're going to say that. Nobody wants to ever look bad. The idea here is that, and I try to put it down, it's more like, do you know the patient? Do you know what their expectations are? Where are they in line with yours? That's the whole point here. I wrote down a few things here. If a patient is ready, already presenting multiple colored teeth and doesn't seem to care about like whitening or anything cosmetic, you can expect that when you start changing their teeth or putting new teeth on from implants or bridges or things like that, that you know are going to be very difficult or already are in red on the colors or something else or the scalloping, they're still going to possibly be a green in the green zone because they already accept that their teeth, they don't like to smile. If you look at Morgan Freeman, for example, you look up his cases online, he doesn't ever have hardly any pictures that he actually smiles with his original set of teeth. You can do some research on him, and you'll see some of how bad his teeth really were. He's had them all redone, and they look very white. But you can look at his new teeth now. He smiles with them, but he doesn't smile, back in the day. His teeth were horrible. Most cases are kind of in this expectation zone. You know, in the front, people care. Vanity, like I say, is at the top tier, pain, and then function. So you got to address vanity at all times. Pain, of course, you always got to address when they come in as emergency. And function, you know, people don't really understand function. They don't understand. They just know it has to function. Like that's a given. But patients' concerns are first vanity, because if they break a front tooth, they're coming in the door. Pain, they're still going to come in the door, but they can take pain pills and stay at home for a little longer and linger on and push that dental appointment back. Function, plenty of patients come in 10 years later when they don't have much function on one side. The only reason why they came in is because the other side now finally broke down, and now they're like, I can't chew. Well, you know, why didn't you come in 10 years ago and fix it along the way? But they just don't do it. Function technically is down here. Vanity, pain, function. Here is where when I see a patient and they can't make a decision, I do a denture piece, I do some cosmetic work, they need some outside advice. They need somebody else to confirm that they look beautiful. I'm not in the beauty business. If you are, if the dentist is, great. That's not, it's subjective. It's kind of like your definition of love. It's just yours. It's not anybody else's. But there's a lot of people need other people to tell them that they look great because they can't even make their own decision. Those are the tough ones, especially when it's a husband or wife that's making the decision and they're not there to give you the stamp of approval. So you deliver something, they go home, the spouse hates it, tells them to go back and have it changed. Well, you just can't change it. You just cement it. You got to cut it off and start all over again. And then they got to pay a new bill, and they don't want to do that. So then you get in an argument with them. But they said okay at the time when they're in the chair, and then they make up some excuse why they don't want to do it. Or they got to have some other family member. Or there's signs already on the wall. They have all this plastic surgery done. They're always getting their hair done. They're very meticulous about their looks. There's nothing wrong with that. It just becomes a red case. You really got to get your ducks in a row for that person, or let somebody else handle it. If it's something that's already red on the other smile characteristics and then they come up as a red and you think that they're kind of a red based on the expectations and that you don't think you can meet them, or you're questioning whether or not you can meet their expectations, be honest with the patient, be honest with yourself. Don't accept the case. Let the patient find somebody that has the same expectations and can deliver whatever they want. It's better not to start the case. Don't waste time. Don't waste their money. Don't get into a headache letter just because. You want to make sure you're both in agreement and have the same expectation for the care. That's exactly what this assessment is supposed to do and handle.